Deukmedjian here at the Duke Spine Institute in Orlando, Florida, or near Orlando, Florida. We're actually on the Space Coast. And today we're going to get started right now with our third surgery of the day, broadcast live over the internet around the world for free. This is part of our commitment to education of the public about state-of-the-art advanced spine care in an effort to answer questions and give clarity and eliminate myth. And there's just a lot of misinformation out there about spine surgery, spine care. We want to clear it up. Our patient has graciously allowed us to broadcast. Obviously, we're not going to share the identity of the patient, but we are going to allow you to watch the surgery. Okay, Dr. Deuk here. We're going to get started, okay? I'm going to give you some numbing medicine, and we're going to start placing our needles. Just lay still, all right? We're strapped up top. All right, that's just my hand pushing on your back, okay? Now, the patient has a combination of herniated discs and degenerated discs with stenosis or narrowing in the areas where the nerves are. And that's why we're moving from side to side, because we want to treat the pinched nerves as well as the back pain. We want to treat both. We want to get rid of both. That's our goal. Little numbing medicine, okay? Little stick and burn. He's doing great. Yeah, you're doing great. All right, I injected 8 cc's, needle down. We're going to get started. If you feel any pain or discomfort, let me know. The line here is the middle of the back. The patient's laying on his belly, and our anesthesiologist is up by the head, maintaining the airway and everything else, cardiovascular and pulmonary. All right, we're going to get started. Now, where I go in is determined by the disc that I'm treating. So right now we're treating L5-S1, and our patient is not a heavy set person, so shot. He has in good shape, and so we don't have a lot of thickness to get through. So I can aim differently than I would, say, a heavier set person. You okay? All right. Just let me know if you have pain. Try not to move. Just say ouch, and I'll give you more numbing medicine. Shot. I'm aiming for that L5-S1 level. That's the disc that's right in front of our needle. You're doing great. Everything's fine. Shot. But we're getting closer to where we need to be. And you'll see me flip the needle around, backwards, forwards. You're doing good. Don't move. And the reason for that is that there is a directionality of this needle. And there's actually a beveling of the surface that allows me to navigate with this needle. And, you know, whenever you're navigating L5-S1, you're really navigating a very narrow space, like right now. Literally, the width of this needle is probably 1 millimeter, and I'm using just 1 millimeter to get through this area because it's tight. AP. So I'm going to use the side view X-ray as well as the front back. We're moving to an AP view, which is front back. And it gives us a different view of the spine. I want to see where we are relative to the anterior posterior. Oh, it's perfect. All right, let's go back to a lateral. So we're targeting L5-S1 on the left. We're going to target on the other side L3-4 and L4-5. The first step in every surgery is what's called the exposure, basically getting down to where we need to be. You okay? Just bear with me, all right? Any pain? Shot. AP. So we're right there, but we're not quite in the disc. We're just starting to enter the disc. And I'm probably caught up on the end plate if I had to guess. But it's a good location. The disc is collapsed. Thank you, Jordan. Where do you feel that?
On the left side.
Shot? I mean, it looks perfect. Huh, Luis? I think that may be the... Oh, we did it. It's better to be lucky than good. So, finally got it in, and he kind of relaxed a little bit. How long have you had your back pain for?
94.
94. So he's had back pain. Pardon me?
That's when it started.
Started in 94. All right. All right, you're doing great. We've got one down, 2 more to go. None of this is going to be easy because your discs are so collapsed. You know, his pain started in 94. Presumably, he had a herniated disc in 94. And that herniated disc started with a tear in the disc that ultimately led to the disc collapsing through inflammation. And so his discs are collapsed, but unfortunately they're also still painful. So the goal is going to be to get rid of the pain in the back by treating these discs that are collapsed, because it's not the collapse that's causing the pain. It's actually the inflammation in the annular tear. That's what we're after. Let's see what we can do. On the wag side, it looks decent, but I think we're still wagged off a little bit. Let's just play with it and see what we can do. We're adjusting the X-ray image so that we can get a cleaner image. Clearer image. Huh?
We tried the opposite direction.
Yeah. You know, I don't think it's too bad, honestly. The space we're shooting for is so tiny. You okay?
Yeah.
I have a feeling we're going to have to split the difference. Shot? Shot? You're doing good. I know it's a little uncomfortable for you, but we're almost there. Shot? 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 Let's get an AP. So I'm right on target for the next disc, which is L4-5. And we're going through the right approach. And I'm on the right side of the patient, so everything's going well. Yeah, it's actually perfect. You can see the patient has some scoliosis of the spine. We're not here to fuse them and fuse the scoliosis or correct the scoliosis. Scoliosis doesn't need to be corrected 90% of the time. We want to get rid of his pain. That's why he's here. He wants to have no pain in his back and in the legs, and that's what we're here to do. I'm going to get rid of that pain today. Shot. Almost done. Where do you feel that?
On my right side.
Huh?
My right
Just the right side, not down the leg. Shot. It's kind of like a little dance I have to do with this needle. It's quite incredible, to be honest. I'm placing the needle into a space that's smaller than the needle. You're fine, just relax. I know it's uncomfortable, but we're almost done. Shot. Shot. You're doing fine. Everything's okay, I promise. Shot. All right. Wow. A little bit of progress. Try to relax for a moment. Take a deep breath. Good. And another one. Good. And take one more for me. Try to sneak it in there, but I couldn't. All right. Well, we're right on the precipice where we need to be, and I'm happy with that. Shot. Yeah, it's actually almost like a little drill just making its way past the bone spurs, you know? Sometimes that's how you have to use this. It's really... What do they say? If you can't make it, jiggle it? That's amazing, huh? Just jiggle it in. Got to do a little jiggling dance. It's working. Shot. I'll bet you were in far enough to do a discogram. You doing all right? Yeah. Okay. Let's get L3-4 lined up. So, needle jockeying techniques. This surgery is all about jockeying the needle. The needle is the hardest thing to do, and you can see somebody like this that has really bad degenerative disc disease, you can still fix their disc with a laser, but you got to get into the disc to fix it. So we're lucky we were able to jockey it and get it in, but I have to do that quite often, as a matter of fact. So a lot of experience putting these things in. That's really helped me quite a bit. Some of the patients I've done lately I wouldn't have been able to do 10 years ago, 15 years ago when I was starting, because the amount of collapsed disc is just too much. And I've learned some tricks with the needle, you know, these jockeying techniques of twisting and bending and re-angling that have helped me. Okay, 2 down, 1 more to go. You're gonna like watching this when it's all done. Shot. All right, so we're aiming for 3-4. I'm gonna use the same incision. Shot. Because there's no point in putting another incision. Shot. When I can get it through one incision. Shot. All right, so let's get an AP, see where we are. You have a question, Diego? Huh?
No questions yet.
All right. All right, so I'm not happy with where I'm at. I'm going to relocate and try to move a little more medial. I think I can do it. And the reason why I'm not happy with that is because the spine is twisted away from me, away from his right side. Shot. So I had to accommodate that twisting. I have to deal with it. Shot. And that's what I'm doing. I'm basically working around it. Shot. All right, it's not a bad trajectory. Let's get another AP. Again, once I have to go back and forth between 2 different views, a side view and a front view, to really know where I am. That's pretty good. We're getting close. Yeah, you're doing good. Are you okay? Hmm. We did visit the potty before surgery, right? Yeah. Shot? AP? You okay? I'm going to, let me see where we are in the lateral. I think we're off on orbit. Can't tell if that's better or not. Go the other way. Shot. That's better, I think. Yeah, a little more. Let's see what happens. That's better. Well, you okay? All right. Any pain? Where do you feel that? Uh-huh. All right. I want to use the knife and make a little bit bigger incision. I'm not happy with my trajectory. You okay? Yeah. Where was that? On your skin? Yeah. All right. Okay. I'm very happy with our progress. I just want to get this perfect. So I'm repositioning things to make it even better. Shot? All right. Shot? The closer we are to getting it perfect, the better it is for you. I know that makes sense. You feel anything? Shot? All right, I'm very happy. Are you ready? We're going to put you to sleep in a few minutes. Okay, I got to test a few things, okay? Now, you said you've had your back pain since 94? And you injured it in 94, right? And did you ever have surgery? What'd you have done? You said that was what year?
Thank you.
Oh, so you injured your back when again? Oh, so you injured your back in 93 and you had surgery the same year. Is that correct? Yeah. And did the surgery help you? Was it a pinched nerve? I see. Did it help your leg pain? Did it take away your back pain? And how long did you go without having any pain? 10 years. So you had from about 93, watch the scope, to about 2003 with no pain. And then it started coming back. All right. Are you comfy? I hear you. Did you go to the bathroom before surgery? All right. You're going to be okay, I promise you. You're going to be fine. All right, we have 3 discs, and we're going to be testing them. We're going to put you to sleep soon. How bad is that on a scale of 1 to 10? Huh? 10. Is that where you typically get back pain? L3-4 is a 10 over 10. I'm sorry, I had to do that. I had to test. I want to make sure we're in the right spot. That's one of your bad discs, okay? That's good news. That pain will be gone when you wake up. And you won't get it back again. Okay? All right. Is that better? Sorry about that. Does it feel better? All right. This is going to be a tough one. I can't get any out. It's too collapsed. Wait, shot? Wow. There's no disc left. How bad is that? Give me a number on a 10? All right, so that was L4-5 was a 10/10. Is that where you get your back pain?
Not that hard.
I know it's not that bad, but is that the area that you get it?
Yeah, right in there.
So L4-5 was a 10/10. High meaning high of a number. Okay, sir, we are literally almost done. But you know we're here to fix 3 discs, right? Huh?
Yes.
How many did we test already?
50.
How bad is that on a scale of 1 to 10?
Pretty close to 10.
10, 9, what is it?
Good.
All right, 10 out of 10 at L5-S1. When you wake up, we'll be done with your surgery, and those pains will be gone. My pleasure. I want you to count from 1 to 100 in Scandinavian, as loud as you can. All right. Count out loud for me, 1 to 100.
1, 2, 3, 4, 5.
Okay, so for those of you watching, we tested 3 discs. This was the L5-S1, and this was a 10/10 pain. You can see his back tighten up. He clearly responded. He's a tough guy. He didn't want anybody to really hear it, but I could see him gritting his teeth under the sheets. And, you know, he's got 10 out of 10 pain in all 3 discs. So we know we're doing the right thing to fix his back pain. A lot of people don't understand back pain comes from damaged discs. Herniated disc, degenerated disc, bulging disc, annular tear. And it's the annular tear that's a source of pain. Okay, let's go ahead and, can I proceed, Sean? We're going to use our x-ray machine to remove now this needle, but we're leaving the guide wire. And I'm going to use this guide wire to navigate down to that bad disc and repair it with the laser. Shot? Okay. As I take the needle out, I want to make sure the guide wire doesn't move. Shot? You can see the guide wire is thinner. I'm at the L5-S1 in case you didn't know that. That's the bottom disc. Look at the dye is mostly gone. That's because it went back into my syringe. I injected it into the disc and then it came back out. And it stained the nucleus pulposus. 7mm incision. The whole surgery will be done with a tiny little cut. We're going to use the dilator to basically spread the tissues open to get into the disc and repair it. The beauty of the surgery is there's no metal, no fusion, no laminectomy, no bone is being removed. This is a very safe surgery compared to open surgeries, and there's no general anesthesia. Patients go home usually about 30 minutes to an hour after their surgery. This is outpatient surgery, by the way. This is not being done at the hospital. It's being done in our surgery center at Deuk Spine Institute. Our surgery center has better equipment than a hospital for spine surgery. Really all we do here is spine surgery. So our equipment is really designed to do state-of-the-art spine surgery. We don't do other types of surgery. And quite literally, we've had the hospital borrow equipment from us in the past. Were you here when the hospital borrowed equipment from us?
No.
That was a long time ago. All right, take that. This thing is kinking a little bit. He's wiggling a little bit. I'm okay with it. if you're okay with it. I want to redirect this. Let me see, shot. I want to make sure we're aiming south. Shot. Okay, I think we're getting in there. Yeah. We're in, like Flynn. That's it right there? So what I've done, folks, is I've placed this dilator down through the tissues and not damaged anything. I'm just spreading apart the tissues gently and entering through the tear, and that's why the patient doesn't like it. I'm going through that tender, painful annular tear and herniation. The whole reason he's here is that tender little tear. And so I had to go through that tear to get inside the disc, which is great because then I'm not damaging anything else. I'm just going through the herniation itself, which is already damaged. So we're using the damaged part of the disc to get into the disc. So we're not creating any new damage. Any questions? Shot? That's great. So you can see the collar is sliding down. We're bringing our tubular retractor in. Shot? We're going to do the whole surgery through this little tube.
Yes. Yes, we have one question from Facebook.
All right, we got to bring our dilator back a little bit. Yep, give me 1 second. Go ahead, Luis. Pull the dilator back about centimeter. Yes, we'll take the question.
Do I need to stop taking my medication before I go and get the DLDR?
Great question. So someone's asking, do I need to stop taking my medication before I get the DLDR? A little bit. The question is what medicine, and I don't really, that's good. I'm sure you don't want to share all that information here. Why don't you give them Sheena's number and have them call Sheena, and we'll get the answers for you, so you don't have to tell everybody in the world what medicine you're on, but
Yep.
unless you want to share it. But as far as pain meds go, no, you don't want to stop your pain meds before your surgery. You want to stop blood thinners. You want to stop non-steroidal anti-inflammatories like Motrin, ibuprofen, naproxen, Aleve, BC powder, Goody powder, naproxen. All those over-the-counter anti-inflammatories. He's wiggling around a little, just in case you didn't know. Maybe able to make him a little more comfortable. So you want to stop any kind of anticoagulants, any kind of antiplatelet. You want to stop anti-inflammatories like ibuprofen, Advil, Aleve, Motrin, naproxen, naproxen. And then you want to stop herbal medication like ginkgo biloba, turmeric. You want to stop fish oil because all those things make you bleed. And honestly, if you didn't stop them, it's not the end of the world. But we prefer that you do stop them so that we need a scope on so that you don't bleed during surgery. Obviously, if you're on an anticoagulant like Coumadin, warfarin, or you're on an antiplatelet like Plavix or I think Eliquis, then you definitely need to stop those. Okay, we're inside the L5-S1 disc. It's a little blurry, so I'm going to try to sharpen up the image with some focus. There we go. And you can see the disc is right in front of us. There's a tear. You can see the blue line of the tear. He's still moving around a little bit more than I want him to. How's our irrigation? Because I got very little irrigation. The fat you're seeing is from the foramen. Remember, we go through the foramen to get into the disc, so we're going to be pushing things from the foramen back into the disc, most notably the herniation.
Jason, I'll be
Rita, I don't know what you're doing, but we need more flow. I don't know what you're doing over there with the flow, but we need it. We need it good flow. Lazy, sluggish flow is not good. Luis, why do we have lazy, sluggish flow?
I don't know if,
Have you gone over how to operate that thing with?
Yeah.
All right. Seems better, yeah. I don't know what you did, but it's definitely better.
Increase the pressure now? Yeah.
Uh,
We have a question from YouTube.
Sure, I'll take the question.
We have a patient from Washington State wondering if he was to fly there, what is the expected wait time for the surgery? Expecting insurance takes care of it.
Yeah, so somebody's saying if I fly there, which by the way, most of our patients do fly here to Florida for their surgery, because this endoscopic surgery is not available in Washington State. It's not available anywhere really. Just here, since we're the pioneers of this particular technique. Now, endoscopic surgery, there's lots of endoscopic surgery being thrown around. But there's really only true endoscopic surgery, which is done through an endoscope like we are, with a tiny little tube. And the kind that you want is called transforaminal endoscopic, for the lower back at least, not for the neck. Long story short, the way we do this is people fly in on Sunday. They check into their hotel just down the street. And on Monday, they come in and we do all the paperwork and I get to meet them and answer questions. Dr. Damola will do a history and physical. And then we have one of our primary care docs do a medical clearance if the patient doesn't already have it. EKG, blood work, chest x-ray if we need it. And then then the next morning, Tuesday morning, is surgery. And then Wednesday they go home. So you can fly home Wednesday evening probably, since you're on the West Coast. So you're kind of going back in time, so to speak. So you should arrive at a decent hour. So really it's a Sunday through Wednesday process. As far as getting the surgery scheduled, we need to first review your imaging and your history. So you could go to, Diego, would you post the link, mri.dukespine.com? Basically, it's our site where you can upload your MRI images off of a CD from your computer, or you can just send us your CD, and we're going to review the images. I look at them myself personally. I'm Dr. Deukmedjian. Diego will post the link for you, but once I've had a chance to look at your images, and then we do a video conference with you over Zoom. And on that video conference, I'm going to review your MRI. I'm going to answer any questions you have, and we're going to make recommendations for treatment. Then after that, if you decide you want to move forward with the treatment with us, you can. We would have you talk to Joseph. Joe Larson is in charge of scheduling. And you basically would pick a date with him, and then you would come out, and everything would pretty much be done and ready to go. So I don't know if that answers your question, but when are we available to do surgery? Like, what days do we have open? I know we're pretty full, but you just have to talk to Joe. Joe can tell you exactly what days are available. We pretty much operate Tuesdays and Thursdays unless I'm out of town. So it'd probably be a Tuesday or a Thursday. We do have the ability to operate other days, but currently we don't, because you need an anesthesiologist to do surgery like this, and our availability of an anesthesiologist is still limited. So we have to make arrangements, And that's all part of the scheduling. I don't keep track of the anesthesia availability. That's something our scheduling office does. And of course, Luis has to be here. Right, Luis?
Yeah.
So, I hope that answers your question. Diego, why don't you run the animation showing what already? Do we go through 3 liters already? Oh. Yeah, go ahead. You can change it. You can see how this disc is just, wow, so collagenized and it's been just, this is all inflammatory damage we're seeing. Diego, are you running the animation?
I will run it right now for back.
All right. Did you already change it?
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain,
You giving me a countdown?
3, 2, 1. You are now live.
All right. So hopefully you learned a little bit from the animation about what causes the back pain and neck pain. It's actually inflammation. How many of you have gotten a thorn stuck in your finger? Once that thorn goes in, it hurts just for a second, right? That little poke. But then if you leave it in there for a while, it starts to hurt more and more, and pretty soon your finger's red and swollen and you can't even touch it. It's so tender. Well, that red, swollen, tender is inflammation, okay? And that's what's hurting you so bad, is the inflammation from the thorn in your finger. It's not the thorn that's hurting you. The thorn is causing inflammation, but inflammation is your own body's response to that foreign body or that thorn being there. Well, it's the same thing happening here. The annulus fibrosus, the tear, normally isn't painful. But when the nuclear material, the nucleus pulposus, sticks in there, and it creates inflammation just like the thorn does. And then that inflammation is what hurts the patient. It causes the bad back pain. And the reason why they're able to feel posterior tears is because the nerves to the back of the disc go to the part of the brain that is responsible for feeling sharp pain. That's the primary somatosensory cortex. And it's like a road map. It builds a map of where the pain is coming from, and they can feel it. It's in their lower back or their neck. The patient can. All this stuff I'm telling you, 99% of doctors don't even know. So if you are learning from me and you're learning this stuff, then you go talk to your doctor about it. They're going to be like, what are you talking about? Never heard of that. This is hot off the press, so to speak. He seems to be a little more responsive than I would normally want him to be. But I know you want to be cautious. Huh? All right, as long as you're happy, I could live with it. All right, I'm fine. This is a bone spur, by the way. We don't get rid of a lot of bone spurs, but once in a while, we have a bone spur we need to get rid of. And this one right there, melting away with the laser, is one of those bone spurs. Right there, you see that? If you're not sure what I'm talking about, just hit rewind. Go back and look at it before I started blasting it. I know, buddy, we're almost done here. What a mess, huh? All this is arthritic stuff at the back of this L5-S1 disc. It's just horrible. For those of you who have done enough of these surgeries with me, you see that what a mess it is. That is a herniation if I've ever seen one. What a mess. This has been around for a while. This is not new. Look how like scraggly it looks. There aren't many tools I could use to get rid of this. This is pretty much it, and maybe a drill, like a drill bit. You know, sometimes we call them shavers, but sometimes a drill can be used. It's all calcified. That's what all that flaky white stuff is. He's not liking it.
We have another question.
I'll take the question.
For patients that cannot make it down to Florida, is there any other doctors, practices, or treatments you could recommend?
So patients that can't make it down to Florida, are there other doctors, practices, or treatments? Yeah, it's a great question. Well, it's a tough one. Tough one. Look, this is your spine. And the reality is that we're not popping pimples here. We're dealing with the spine. And if you mess the spine up, it's something you're going to have to live with for the rest of your life. So the truth is that I don't have a lot of confidence in most spine surgeons, right? That's the truth. And I know they have complications quite often. We have extremely rare do we have a complication, extremely rare. So I cannot in good faith recommend anyone because I don't know of anybody that I would trust to do my own surgery. So I'm sorry, I just can't. For a lot of reasons. One reason is they don't know how to do this kind of surgery. And the second reason is most spine surgeons, I feel, don't treat the patients properly with respect to what they do to fix the problem. And therefore, patients continue to have pain and symptoms after spine surgery. So it's hard for me to recommend someone. I don't know of a surgeon with the same caliber of treatments that we have at Deuk Spine. You know, you're not asking me for a recommendation for a steakhouse. Yeah. You know, if it was a steakhouse, I could give you recommendations because, yeah, they're all different, but they could be good. The differences could be good differences. In surgery, spine surgery, the differences usually are not good. And I'm sorry, but you just have to talk to people that have had surgery. And the best thing to do is to find people that have had surgery with a similar problem to you, and where did they go? And did they have a good result? and then talk to the surgeon and have an honest, frank discussion about, well, what's the chance of getting rid of my pain? What's the chance of a complication? What kind of complication can happen? So you just have to do your research, but I don't have anybody I'd recommend. Why is my visibility so bad here? I know there's a little bit of oozing, but any way we can improve that? This is one of the worst calcified herniations I've ever dealt with. That's what this is, by the way, calcified disc herniation. They're really hard, and this is what's been pushing on his nerve over here on the left. It's so obvious. There's nobody else that does this endoscopic surgery, by the way. Everyone else does what they call endoscopic. They're going to be opening your back up, and they're going to be drilling bone and ligaments away. So you just got to be real careful who you go to. I would honestly make the trip to Florida. I think it's worth it. I mean, if you had something like cancer and there was one place to go to get it cured, that's where you go. You don't mess around with anybody else. You go to the place that can do the job right, that's proven over and over again. So I just don't know anyone else that I think is any good, that I trust. This is a one-of-a-kind surgery. All right, I'm almost done here. Then we're going to move on to the next two discs. You can see this is taking a long time because the disc herniation is calcified. It's white and it's just full of calcium. That's why it's just not dissolving very quickly with the laser, but the laser is definitely doing the job. It's just slow. You can see how the laser breaks it up into little pieces. Yeah. Well, this is a good one because we don't get a lot of calcified disc herniations, but that is what they look like under the microscope, so to speak. Let's get a good look at it with the grabber. I'll bring the grabber in. That'll stem some of the redness, and you'll hopefully be able to see. Yeah. Just about done. One more minute on this side. And I'll move over, Luis, to your side to finish up. Hey, the great questions, by the way, and I'm sorry I don't have all the answers you want. I don't have a lot of confidence and respect for most other spine surgeons. I just don't. I don't care if they're neurosurgeons or orthopedic. I've seen so many quote-unquote good surgeons and good places, like I won't name names, but places you're supposed to be able to go to get the best care, and people end up getting horrible results, very inconsistent results. So I cannot recommend somewhere else. All right, done there. All right, we just finished up the L5-S1. Scope is off. Yep. Now I'm going to put in what's called an antiseptic. It's basically, we've never had an infection with these surgeries. And it's, you know, honestly, mostly the nature of the surgery being endoscopic, being a small incision, and really not much chance of getting an infection. But the infections can always happen. Lay still. So it's standard practice during spine surgery to cleanse the wound before you close it up with antiseptic, and that's what we're doing. The antiseptic we use is betadine, developed here at NASA. We're not at NASA ourselves, but we're very close. We're about 10 minutes away. We are on the Space Coast of Florida, and that betadine is used all over the world. As I've said in other broadcasts, it was really created to prevent astronauts from bringing home astronomical diseases from space. I'll give you an example. How many people out there are Stephen King fans? Anybody here a Stephen King fan? Huh? You guys know who Stephen King is? One of the best authors, American authors ever in the history of our country. And he writes books about mostly horror. So there's a movie from a long time ago in the 80s called Creep Show. And if you know what I'm talking about, huh? 3-4, you want to do 3-4? Yes. All right. He's still moving around a little bit. This one, right? So Creep Show is a series, it's like a little series, a mini series of about 4 or 5 little horror vignettes. Okay, kind of creative little horror stories. And if you're a Stephen King fan, it may surprise you to know that Stephen King not only wrote some of the stories for Creep Show, but he also acted in one of them. He acted in one of them. He was a farmer. And in his little horror vignette, a meteor came down and landed in his farm. And it cracked open and he touched it. And this disease got on his fingers. And his little vignette is about how the disease, which was this green material, like a fungus, just took over and ultimately led to his death, and everything got covered in green stuff from space. So that's what NASA was trying to avoid with the betadine. So betadine contains iodine, and iodine has been found to be very effective at preventing microorganisms like bacteria and fungi and protozoans from surviving. So they did their best. They created this betadine over at NASA in hopes that it would
works better than anything.
prevent anything serious from coming back. He's a little lighter than we want him to be. He's responding. I don't know if you can help him a little bit. All right, well then in that case, let's just wait and give it a minute to work. So type in Creep Show Stephen King green stuff on Google, and you'll see what huh?
I think they're remaking some of those episodes.
Are they? That would be great. Those were amazing. I remember watching them as a kid. I was like 12 or 13 years old. I was just terrified. But I love being terrified by horror stuff. Stay still. Yes, Diego.
Dr. Deuk, are you familiar with the Christopher Dunchich situation?
Christopher Dunst.
Yes.
Yes.
A viewer wants to know your opinion.
I don't know enough about Christopher Dunst to give you an opinion. All I know is that he was a neurosurgeon and that he had a lot of patients of his that died in his care as a result of his care. And I've read some of the transcripts that are public that you've all read. He's just moving a little too much. And some of the comments that he's made, and it's clear to me that this guy was probably, based on the comments he made, he's probably on drugs, which wouldn't surprise me, right? I mean, how many people are on drugs these days? Not me, but a lot of people do drugs. And he's a neurosurgeon in a high-stress job. Maybe he was doing drugs and just got, did some crazy stuff. I don't know, but it's going to be interesting because he's in jail, right? And let's just presume he's not getting drugs. I wonder if his thinking and behavior have improved in prison. It would be interesting to see, because if he gets normal in prison, then obviously it was drugs. He's not getting the drugs in prison, presumably. So if his behavior becomes normal, then it was drug related, which it sounds like he was doing drugs. If you ask me, he was doing a lot of partying and shot. From the transcripts, sounds like he was doing alcohol and drugs and just really not being a very responsible person. Certainly not a responsible neurosurgeon. I don't condone any of that behavior. And I think this whole glorifying a neurosurgeon whose behavior is so atrocious, I mean, it's good and bad, I guess, because it makes people aware that even the highest trained doctors in our country can actually go bad and do harm. So people need to be aware of that. But at the same time, it kind of sucks that that's what they're emphasizing. Why don't you emphasize neurosurgeons that actually save people's lives and do good things, Or is that too boring to put on mainstream media? It shouldn't be. Why can't we glorify good? Why do we have to glorify bad? I think that speaks volumes to society as a whole, that they want to watch that kind of stuff. And it's not just that program. Everything is sort of shifted to that theme of evil, death. I mean, look at this Korean program that was on. This Squid Games, right? Why did I watch it? Because my wife's Korean. Sometimes I think no, I'm just kidding. I shouldn't say anything, but she's a little crazy Korean sometimes, but I love her to death. But the point is that program is extremely violent and it glorifies killing. And I don't agree with that. I may be an old-fashioned kind of guy, but I don't agree with that. I don't think we should be fascinated and supporting and reveling in evil. We should be praising people who are good and do good things. So how do I feel about the neurosurgeon? I think if he's truly crazy, if they prove that he's psychotic, schizophrenic or something like that, some kind of organic brain disorder that he couldn't help himself, he's just a crazy neurosurgeon, right? But you got to ask yourself, how did he make it through residency and medical school? How come no one caught it? I think the story is important because it highlights, like, how do some of these neurosurgeons make it? We had neurosurgeons that shouldn't have made it either. We had a neurosurgeon in my program who was brilliant, but the guy was crazy and he killed some people during residency. He did things he never should have done. You know, he was directly, personally responsible for some really bad medical care. I won't give you his name, but he trained 1 year ahead of me or 2 years ahead of me. And one time he took the patient to the operating room to take a brain tumor out with the chairman of the department, Dr. Friedman. And this resident went in and positioned the patient on the operating table and turned the head and pinned the head and shaved the hair and made the incision, opened up the skull with the drill, and started to take the dura off. And Dr. Friedman came in and started digging into the brain looking for the tumor. Except Dr. Friedman, who's a tumor specialist, could not find the tumor, even though he was in exactly where the tumor was supposed to be. And then Dr. Friedman walked over to the MRI and looked at it, looked back at the patient, and said, "You opened the wrong side of the brain." The wrong side of this patient's brain was open. Can you imagine? I mean, I could never in all my days ever imagine that kind of carelessness, stupidity, whatever you want to call it. But that was a neurosurgeon that did that. He's practicing today. Shameful. I mean, the stories I could tell you, you know, of fellow neurosurgeons. And you want to know who I recommend for spine surgery? Hell no. I don't recommend any of them. Most of them are pigs. I hate to say it. They're greedy, selfish pigs. And I don't respect them. And I can't recommend people to them. But the reality is that this crazy guy, this whatever he is, I don't know enough about him. I don't know if he was a drug addict or if he was just truly crazy. He should have been picked up on, you know, during all those years that he was working in the neurosurgery program, wherever he did his training. I don't know where he did his training. I haven't studied him. I don't really want to spend a lot of time on people like him. But I'm glad they caught him, and I'm glad that he's no longer harming people. I don't know if that answers your question. I just don't know enough about him. I never met him before. I've never heard of him before. I just read the transcript. I need my laser pedal, guys. And I think that it's either drug related or it's, you know, sounds like a mixture of drugs. When you listen to what he says, it's like probably cocaine and maybe crystal meth. That's what he sounds like, cocaine and crystal meth. There could be some other, you know, narcotic abuse going on there as well. But to me, it really sounds either delusional, like a schizophrenic, psychotic, delusional, or it's drug related. And I would put money on drugs. So.
Our viewer says all good points, doctor, and does recommend you to watch that Peacock series about that doctor.
I don't know. Is it factual? Is the series factual? Are they presenting things factually? Has anyone watched it? Do you know? Do they tell you why he is this way? Do we know why? No? Has the trial happened for him yet? Has there been a trial yet? Has he had a trial yet, this doctor? Anybody know? Has he gone to trial? He did. So do we know if they found him insane? Well, yeah. Yeah. I guess you could say it's just a little too painful for me to watch. And the truth is that I don't have a lot of time, free time. I ask my staff, I send them emails at midnight, 1 o'clock in the morning to do things. I'm always working. And I don't have a lot of time to watch TV. But thank you for bringing it up, and thanks for the recommendation.
So he did have a trial and he was convicted.
Yeah, convicted, I'm sure, but was he found to be, I guess, insane? So if he wasn't found to be insane, then maybe it was drug related. Because I don't think they could convict him if he was insane. So he must not have been a schizophrenic. Are you guys okay?
Yes.
Patient doing all right? Sounds like he was doing drugs. And they held him accountable for that. I don't know. Like I said, I don't know enough about him. But, yeah, unfortunate.
Thank you.
I would say there's probably a lot of doctors out there that do drugs. You know, truth is, doctors, for the most part, are under a lot of stress, like people, you know, and you may think that their lives are always great, but they're not. I know so many doctors with problems, social problems, marital problems. I mean, they're just like everyone else. The only difference is they have a degree and they went to med school or a residency. So how do people deal with problems improperly? Drink alcohol, do drugs to escape. And I'm sure there's other doctors just like this guy that are dangerous. I told you about one in my residency. That guy's really dangerous. I don't know what he's doing now in his practice, but that guy scares me. Yeah, I mean, doctors have personality disorders. Many of them do. Some are narcissistic, and that carries over into how they treat their patients. So, it's, like I said, doctors are humans. They get the same kind of problems everyone else gets. All right. For those of you watching, we are at the L3-4 at the behest of Luis, who asked me to go onto the side and do L3-4 first. And he knows why, because the next disc is going to be really hard to do. It's really collapsed at L4-5. So L3-4 is a bit wider and thicker and easier to get into, easier to treat. But again, if you look here, I mean, that's a herniation right there, that blue thing. If you look here, everything is scarred up from chronic inflammation. And this is the annular tear, by the way, just full of junk. It's full of calcium deposits, spurs, scar tissue, herniation. All the blue stuff is herniated disc. We call that the interposed herniation. And that's where all the pain comes from, is that stuff. That's like the splinter in your finger I was talking about earlier, or your toe. That's what's causing all the inflammation, is this blue stuff right here. And you could see it's caused the inflammation because it's all scarred up. It's like scarred in there. But look how much of it there still is. Okay, why is there still so much nuclear material wedged into this annular tear? If the herniation happened in 93, or actually 10 years later, let's say 2003, that was almost 20 years ago. Why is there still so much nuclear material within the annular tear? The answer is because the disc herniations keep happening. The annular tear has never healed. It's been trying to heal, but it's never healed, so it's weak. And every time the patient bends over to pick something up or goes out for a ride on their Harley and they go on a bumpy road, it just forces more of the jelly out of the disc and into the tear, where it starts another cycle of inflammation and pain. That's why there's so much episodic back pain. It gets better when you take it easy, then you do something, it sets it off. Well, what you're doing is you're forcing more of that nucleus pulposus out of the disc down here and into the tear, where it creates inflammation and pain. That's all annular tear right there. Look at the fibers of the annulus. Isn't that cool? We're trimming them back so they'll regrow again. But this tear right here is just never healed. Probably never healed since 1992 when the pain started. And I'm trying to help it heal right now by zapping all the grunge out and letting it have a fresh chance of healing. All right, almost done here. Another 5 minutes. And then we got one more disc to do. Man, there's a lot here. Look at all this. This is the bad stuff causing all the back pain. All right, great question. Why don't we roll the animation showing what I'm doing. The Deuk laser disc repair.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back
Bringing you back in 3, 2, 1.
I need a countdown. You keep forgetting. I
3,
don't know.
2, 1. I said it.
All right, Dr. Deuk here. We're just still working on that herniated disc and annular tear at L3-4, the top disc. Almost done, but it just takes a long time. I have the laser constantly going, but some of these herniations are pretty big and they've been here a long time, so they get really scarred in. So I just got to keep going until it's done. Some are quick, some are slow, and this is one of those ones that are taking a long time. So it's a good opportunity for you all to ask questions. Just to remind you, Deuk Spine has a Facebook support group called Spine Surgery Support Group. If you go on a Facebook, type in Spine Surgery Support Group, you'll find our Facebook support group. And the nice thing is we answer a lot of questions on it. So if you have a question, we'll answer it. And you get an answer from a real neurosurgeon, someone with a lot of experience doing spine. I was really funny the other day. I was on one of the Facebook support groups, and if I have any fans out there, go to I think it's cervical spinal stenosis or something like that. Cervical spine stenosis. There's a Facebook group. It's got about 6,000 members. And I go on these things, and people are desperate for help. You know, they're like, oh, my neck is killing me. I have so much pain. I don't know what to do. I'm like, well, get it fixed. And there's a group of about 3 members that absolutely hate me because I come in there and I'm like, yeah, we can do this, we can do that, don't do fusion. Basically helping people, giving them information, letting people know they don't have to have a fusion or live with the pain, that there's actually treatments that work. And these trolls, I call them trolls because they really are trolls. They're bully trolls. So just to call them a troll isn't enough. They're really bullies. And they're like, bash on me, like, get out of here. All you're trying to do is sell your services. And I'm like, no, I'm not selling anything. I'm just explaining, number one, why people have pain, because it's a mystery to most people, and they need to know. It's the herniated disc. And then what your options are. You know, you got artificial disc, you got fusion. You know, I go through and I explain why. I show our videos that educate people, and these people just get so angry with me. for sharing information. It's so funny. It's like we got people coming in there posting things like, oh, try Dr. E-Boy's, THC pills. And they don't even get angry at those people. They just get angry at me for actually being a neurosurgeon trying to help. So this one member, she really is a member. Anyway, she says, you shouldn't be talking about surgery because you just make profit off of surgery. And I said, well, what should a surgeon talk about then? Massage therapy? Should I be giving advice on massage therapy? Because I'm not making any money on massage therapy? Is that now the criteria for helping people? I mean, who better to talk about surgery than a spine surgeon, right? Yeah, anyway, entertainment value. But if you wanna help us spread the word, then go join Cervical Spine Stenosis and put some of these trolls in their place. Help me spread the word. Share our videos and animations to teach people about what their options are.
We have another question from YouTube.
Sure.
For out-of-town patients, how soon after the surgery can the patient head back home?
Yeah, so most of our patients at Deuk Spine are out-of-town patients, and they all go home usually the day after surgery. So most people come in on Sunday, have surgery, come and meet me on Monday, and our team, do all the paperwork, answer questions, get everything together. And then surgery is Tuesday, and they can go home Wednesday. You can go home Wednesday, just the day after your surgery, usually in the afternoon. All right, we're almost done. This is L3-4. How are we doing on irrigation? Yeah, we got one more disc to do, but that last disc is not going to have a lot of disc material. It's going to be pretty collapsed. Gosh, just look at this mess in here. You can tell this disc has been damaged for years and years and years. There's a lot of scar tissue inside the disc, which normally there's no scar tissue inside a disc because the disc doesn't have a blood supply, so you don't get scar tissue inside the disc. The only time you get scar tissue inside the disc is when there's severe chronic inflammation that's been going on for years and years and years, like we have in this particular patient. So it's good for you all to see some of the variations in the disease. There's a piece of herniation. Looked like a fresh one. Probably recent. All right. These are all very good questions my audience is asking, and I'm happy to answer them for you. We talked about the Facebook support group where you can get all your questions answered. And we have a great community of people there, by the way. We don't allow trolls. We don't allow advertising either, like people just posting, the advertisements. But we do allow people to discuss different treatments and their experience and ask questions and just share, support each other. And then, of course, there's the Deuk Spine app, which is available on the iPhone and it's available on the iPhone and the
Google Play Store.
Android. I'm just thinking. By the way, we had a patient from England who sticks out in my mind because she went to England. She went to a place called the London, what the heck is that place called? Is Joe there?
I believe it was the London Spine Unit.
Yeah, the London Spine Institute. Was that what it was?
No, they called it the London Spine Unit.
The London Spine, whatever,
Unit. Mhm.
London Spine Unit. All right, very good. And this patient had a procedure, and I know what the procedure was because they described it. And it's a procedure we don't even do in the United States anymore because basically it's been proven not to work. And it's a procedure where literally you put a needle in, and then you put a laser like this, and you go done, and you take the laser out. And you see how much time I spend to fix this disc. And I'm looking around left, right, up, down, backwards, forwards, in, out. All right? They just literally stick the laser in for a minute or two, zapping the pedal without any direction, without being able to see it. It's just through a needle. Remember that needle we took out an hour ago? Anyway, that's all they do. And of course people aren't going to get better. So that's unfortunately the kind of shams and scams that we've got still going on. And people with back pain are desperate. So they're going to do anything that sounds reasonable. So it's really the responsibility of the doctor to make sure that they explain to people what does and doesn't work. And we shouldn't be doing treatments that don't work. All right, just about done. 30 seconds. This was a big blowout, big tear. You can see it from wall to wall. Pretty much done now. I'm gonna just clean this up right here. We'll be done.
We have another question from
I'll
YouTube
take
when you
the
have time.
question.
How does the jelly not leak after the surgery is?
Yeah, how does the jelly not leak after the surgery? Well, you can see the jelly is thick, and it's actually stays right where God put it, in the middle of the disc. But the only reason why it leaks out is because of pressure. Okay? And we don't want pressure. Okay, we want to avoid pressure. So everybody that has this surgery is told not to do any bending or lifting, any kind of really strenuous physical activity until this heals. And it will heal, by the way. And when it seals off with collagen, this is what it seals off with. Your body makes the collagen and seals it off. It takes about a year to fully seal. Okay? That's all fat, by the way, right there. We're done at this level. So the reason why the jelly doesn't come out is because people are careful after the surgery. I tell everybody to wear a back brace. We give you a back brace, and you wear it during the day when you're out of bed. You don't wear it at night when you're sleeping. And the back brace just keeps your back straight, keeps you from bending. That's the key. No bending. So no bending and no picking up any kind of weight. We give people a 25-pound lifting restriction. And as long as you follow those simple instructions, you won't have a problem with your disc leaking jelly. But great question. 1% of my patients, 1%, 1 in 100, re-herniate their disc. And every time it's been a story of, yeah, I know I did something I shouldn't have done, except for I think one patient who she couldn't figure out what she did. But everyone else, now I've done 1,350 of these surgeries, so we've had about 13 patients with re-herniations, where they re-injured the disc, they popped out another herniation at the same place that I fixed. Push down. So, yep. But I can tell you pretty much every time they were doing something they're not supposed to do. Great question. So the Deuk laser disc repair is an amazing surgery. It's minimally invasive, works wonders, but 1 in 100 patients will herniate their disc and need surgery again. I'm not seeing the x-ray. Go ahead. You can put it in. Just careful not to touch here. Guide wire goes in. You can see Luis's knuckles. Yeah, it's going to be hard to tell exactly where. I like to stick it in hard shot. All right, you can kind of see it's coming out there. Let's go a little more just to make sure. Shot. Like it one more time. You see it? All right, now we're in the disc, so we can take the needle out. Oh, look how bent that is. All right, well, guide wire's in. That's good. Okay, so we're doing the last disc. This should be a quick one. Our patient's nice and relaxed, and that's necessary to get this in. Shot? Because if he's not relaxed, there's no way this is going in. Doc, are you ready? All right. So this is going to be challenging. I've got to look at the x-ray. I've got to play with the angle. Shot. I want to aim it down a little bit. I can kind of see, is the dilator pointing along the guide wire? So I'm actually lifting the dilator, the end of the dilator north. Shot. To get it to go down towards the feet a little bit. Shot. Shot. You can see the disc starting to open up. You all see that gap, that white light? That means the disc is opening. Take that. That's impressive. And the guide wire came out easy. Shot. Oh yeah, baby. Look at that. That is so cool. We call that vacuum space phenomena. Just in front of the dilator is like literally, well, there's no vacuum there now because it sucked air from these holes, but we're basically spreading open this disc that was sealed closed. Alrighty then. You know what's going to happen to that tube. We've crushed so many tubes already. I don't think he's going to crush this one. That disc opened up pretty good. Let's hope. Now typically what happens when you got to work so hard to get a tube in is you're going to scrape the end plates up and you're going to get a little bit of end plate bleeding, which is pretty much unavoidable. We'll have a little end plate oozing, which will probably obstruct the view for you all, but I'm so used to doing them. Now I've done over 1,350 patients, and I do about 2.5 discs per patient on average. So think about that. That's about 3,000 discs that I've done. Yeah, you're fine. Nice job, Luis. 3,000 discs that I've done the Deuk laser disc repair on. We've had literally less than 1 mil of bleeding, like 20 drops of blood. Pretty impressive. Have we done this stitch yet?
Not yet.
Why don't you work on that while I do this? If you can. I'll get it. You work on that. All right, so this will be our last disc that we're fixing. The third one. This was a 10 out of 10 in pain. So it's causing real pain for the patient. Oh, let's hope this turns. It's turning. It's turning. We're good. Yeah, if you do enough of this kind of surgery, you realize that patients with collapsed discs, when you're repairing them, that it grabs your tube between the bones and really just makes it so hard. And you have special challenges you got to deal with. you can actually strip the head up here of the tube and make it impossible to get it out unless you just grab it with a, look at that disc. Man, this is the worst of all three. It's just destroyed. This is what happens when you don't fix your herniated disc, folks. You'll hear it from me for the first time ever in the history of the world. We're taught to tell patients only operate on your herniated disc when it's pinching your nerve going down your leg or when it's pinching the nerve in your arm. But here's another good reason to operate on your herniated disc, to prevent it from going bad like this. Because if I can go in there and get rid of that source of inflammation, which is the annular tear in the nuclear material, then that tear will heal and the inflammation stops immediately. That's why the pain goes away right away. All these patients' pain goes away right away because we got rid of the inflammation source. That means the disc is going to start healing and it won't degenerate anymore. We got to do a study to prove it, but that's what I've noticed over the years. I'm making a statement about it even though I haven't looked at MRIs, and I should. That would be a really good study with our new MRI scanner. Would be to look at degeneration of the disc over years in patients who have Deuk laser disc repair versus those who don't. You know, like a controlled study. That would be amazing. That's going to be for my son to do when he gets older, or anybody else I bring on as a partner. Okay, there's the source of pain at the roof. Luis, what should we do with this? Leave it or take it? Damn right we need to take it. That's where all the pain's coming from, right there. Rita says get rid of it, right? Damn right. That's why we're here. There's no disc to remove. Look at the disc. It's a black hole. There's no disc. This is the source of their pain. It's the annular tear. It's all that's left after 20, 30 years of arthritis inflammation in this disc. This is it. This is all that's left right here. Look at the pinkness. That's where all of his pain's coming from. So, like I said earlier, some discs you got to work at for a good 30 minutes. Other discs are quick. And this is one of those discs that, yeah, the disc is gone, but the annular tear is pretty quick to repair. It literally takes 5 minutes. So we should be done pretty quick. I'd say 5 minutes, Doc. A little bit of fat right there from the epidural space. You guys all starting to understand what we're doing here? Gosh, that thing is right in the way. Would somebody tell Deb I need a cup of coffee? Brew up a cup of Folgers for me. Tell her to do just a half a pot so we don't waste it. Maybe even a quarter pot. But I need something. I need a drink before I hit the road.
Deuk, are you ready for another question?
Yeah, I'm ready for question.
What is your opinion about teaching hospitals and fellow performing surgery?
What is my opinion about teaching hospitals and fellows performing surgery?
Mm-hmm.
It's a really good question. Fair question. 100% support fellows performing surgery. Okay? And 100% support teaching hospitals. 100%. If we didn't have teaching hospitals, you wouldn't have any doctors in the United States. There are 1 million practicing doctors in the United States. Okay? All of them had to go to a teaching hospital to learn. But here's my feeling about it. If you're going to allow your doctor, if you're going to allow a fellow to, what? Yeah. Go ahead. That's perfect. If you're going to let your fellow operate, then you better be confident in their ability. So let me just explain. All training programs, teaching hospitals, let their surgeons operate, okay? But it's up to two people that really control what happens with that operating fellow. First is the fellow, and second is the attending physician. Now, of course, there's other people involved, like the nurses. Like a good nurse will keep an eye on the fellow and make sure the fellow isn't doing anything they're not supposed to be doing. And the nurses talk to the attending surgeons and say, hey, your fellow had a lot of bleeding, during that craniotomy before you got there. They lost 500 mils of blood. They were just sloppy. So it's all about communication between the different members of the team. And the anesthesiologist does the same thing, you know. Everyone's looking out for the patient's best interest. So don't think that as a patient you go to a teaching hospital and, you know, it's like you're being led down the hall of a slaughterhouse. You're not. Everyone is there to make sure the patient gets taken care of properly, but the fellows need to learn. And a good fellow knows their limits. They know that what they should be doing and what they shouldn't be doing. Like, for example, when I called I was about to say his name, when I called my cerebrovascular attending for that aneurysm that I had beautifully exposed and was ready to clip on my own, I stopped. I did not clip the aneurysm on my own. I could have killed the patient if I tried, and I failed. So I know my limitation. I know that I did the pinning, I did the craniotomy, I did the brain exposure, I moved the brain over, I relaxed the brain, I put in retractors, I did everything but clip the aneurysm, okay? Why? Could I have clipped the aneurysm? Yes. If I screwed it up, would I have gotten in major trouble? Absolutely. Would the patient have died? 100%. So I realized, I heard this little voice in my head that said, do not clip that aneurysm, wait for the surgeon, the attending surgeon to get there, and maybe he'll let you do it, okay? And that's what I did. So I called the attending surgeon, I had the nurse call, and I said, tell Dr. So-and-so I'm ready to clip the aneurysm, can I clip it? And the doctor said, no, you cannot, you need to wait for me. So I waited. So there are fellows who are very arrogant, and it's all about their personality, you know? And there are some that are just really bad, and they will go ahead and they will do things they're not supposed to do, and they're not ready to do. And they put the patient's health and safety at risk. But I got to tell you, that's not common. And those kind of fellows should not be allowed to stay and train. They should be terminated. Okay, that's what I would do. But, you know, I've trained many people over the years to operate. And you just have to assess each fellow's ability individually. You have to look at what they're capable. You have to ask questions. You got to get an idea of what their understanding of what they're doing is. Do they know what the next step is? Do they know what to watch out for? Do they know how to avoid injuring the patient? So it really comes down to just really what's called proper supervision of the fellow. And it's not just the surgeon that supervises them, it's the whole people in the OR and out of the OR. Everyone's kind of paying attention. So I think we have to always have fellows, we have to always have teaching hospitals, we have to support them. Unfortunately, this surgery you're watching now is only done by me because teaching hospitals, they're not doing it. They're doing fusions. That's where the money is. They want to make money. And these hospitals make a lot of money off fusions. Heck, I make a lot of money off fusions. We're talking hundreds of thousands of dollars a case for fusions. But why do I offer this surgery? Because it's right for the patient to do this. This is what's best for the patient. Not what's best for me financially, but what's best for the patient. So it's all about, as a good doctor, you do what's best for your patient. Okay? It's a sacrifice, you know, but it's also a trust. Your patients trust you to do what's best for them, and therefore you owe it to them to do what's best for them and not what's best for you as the doctor. But we have a whole country, even a whole world full of surgeons, spine surgeons, doing what's best for them, putting in metal, putting in artificial discs, even though it's not best for the patient. And they're lying to the patient saying, hey, you want the artificial disc because it's better than a fusion. Well, what they're not telling their patients is there's endoscopic surgery like this that's even better than artificial discs. So it's a messed up system right now. I think it will eventually fix itself, but it won't fix itself without broadcasts like this, where we are broadcasting around the world free and teaching people the truth, because you're not going to learn this from the surgeons that are putting in the metal. They're making way too much money doing it, and their loyalty is to themselves and not you. All right, I'm Dr. Ara Deukmedjian here with Luis and the rest of my team. This is our last surgery today. You guys all did amazing. Can somebody please call Crystal and check on her if we haven't already? When?
About an hour, right before we walked in. Her sugar kept dropping.
Okay. Well, thank you for sharing. Will you call her and check on her? Everyone did a phenomenal job today. I just want to thank you all and praise you all. Luis, great job. All right, we're going to, let's show everybody what we've done. This is the first incision. Can you see that? Okay, see that?
Yes, I can see it.
You put a stitch, right? All right, good. And then we're going to put a stitch here too. But let's put some pressure. All 3 discs were 10 out of 10 pain. All 3 discs were repaired. And this patient's going to go home with 2 Band-Aids. And he's going to go home about an hour from now, God willing. And his pain should be gone. All right. I'll be there to answer your questions in a couple of minutes. Go ahead and type up any questions you have. Diego, will you run the comparison video between lumbar fusion, which this patient would have had?
Yes.
A 3-level fusion versus Deuk laser disc repair.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc.
Hi there, Dr. Deukmedjian, and founder and CEO of Deuk Spine Institute. We've just finished the surgery. It's a 3-level Deuk laser disc repair on a patient who has suffered with back pain since, on and off, since 1992. And he had a laminectomy, microdiscectomy done. He went for a period of time for about 10 years where he didn't have any pain. And then in about 2002, the back pain started coming. And the reason he had the back pain, he has 3 discs on his MRI that were right where he pointed his back pain was. So when I asked him, where is your back pain? He put his hand in this area of his back and he literally pointed to L3-4, 4, 5, 5, 1. That is probably the most sensitive and important thing I do on the physical exam, is I have patients show me where their pain is. Because when let's take a look at the pygmy spine. When you look at what could be causing pain in the back, well, there's a lot of things. I had a patient yesterday in clinic who was complaining of tailbone pain. And when I was touching that little tailbone, the coccyx, it put him through the roof. He was like, it hurts so bad. I'm in the middle of a broadcast. Oh, UC San Diego. All right, why not? My alma mater. One of my alma maters. Okay. How's that? Oh, I like that. Except I don't work at UCSD. But, all right, just for disclaimer, I don't work at UC San Diego, but I went there for undergrad, okay? Anyway, so it's very important that patients show you where their pain is. And this patient had definitely pain at L4-5, L5-S1. He had 2 bad discs there. But he also said, Doc, I also got pain down by my anus, just above it. So I took my finger and put it above there, and I pushed, and sure enough, he had horrible pain coming from his tailbone or coccyx. So the treatment for that is an injection into the coccyx ligament. The treatment for the 2 painful discs is Deuk laser disc repair. But you also have the sacroiliac joint. You've got the piriformis muscle that runs across here. So if somebody points their butt cheek, I'm thinking piriformis. If they point just to the side of the butt crack, I'm thinking sacroiliac joint. If they're pointing above their butt crack, I'm thinking discs or facets. Of course, you want to make sure there's no fracture, tumor, or infection. But honestly, figuring out where back pain is coming from is pretty darn easy nowadays. As long as you know what causes back pain and you know the likelihood of what each cause is, like the probability, disc herniations are by far the most common. So whenever somebody tells me I got back pain, they point to their belt area, it's a disc herniation. If they point off to their butt cheek, it's the piriformis muscle. If they point to their hip, it's probably a trochanteric bursa. So I've got it all down now to where I've got a list in my mind. It's called a differential diagnosis, where patients will come in and, yeah, I got pain here, here, and here. And within literally a minute, I know exactly what all their pain sources are. Now, the good news is for each and every back pain source, we know how to fix them. And the only things that really need surgery are discs, herniated discs. When they cause pain, there's really nothing else that works. You got to get into that disc and repair it, just like you saw today with the Deuk laser disc repair. The Deuk laser disc repair is literally the only surgery in the world that repairs herniated discs to eliminate back pain and neck pain consistently, every single time. And that's because with our surgery, we target the annular tear and the herniated disc stuck inside the annular tear. We call that the interposed nucleus, nuclear herniation, as opposed to the actual part that's outside the disc. That doesn't cause any back pain. That just can irritate the nerve, causing leg pain. So I'm glad everybody had an opportunity to listen in on the surgery and learn something. I thought the surgery went very well. Our patients should do fantastic, and we'll have some more testimonials for you tomorrow from our surgeries today. Diego, anything else?
Yes, we have someone who's pretty new to the stream. They say, what does it mean to be board eligible or board certified?
That's a great question. So the question is, when it comes to being board eligible or board certified for a doctor, what does it mean? Well, I'm a neurosurgeon, and there's a board in the United States, a board of neurosurgery, right? And it's basically made up of big players in the neurosurgery world, the who's who of neurosurgeons. That doesn't include me. These are very politically connected people, you know, people that, neurosurgeons that have connections. They're politically active, meaning they're in the politics of neurosurgery. And so they get on the board, and basically they decide which neurosurgeons in the United States they want to make board certified. So it's kind of a, I hate to say it, but like a, not so much a good old boys club these days, because there are a lot of female neurosurgeons now, but it's kind of that mentality of who do we want to let in? So basically, when you complete a neurosurgery residency that is accredited, an accredited neurosurgery residency, and accredited neurosurgery residencies are 7-year-long training. So you finish med school after 4 years and you get admitted into a 7-year training program. That's what I did. So for 7 years, I did neurosurgery every day, learning how to do it. And at the end of those 7 years, I graduated. I got a certificate. The neurosurgery training program I went to at the University of Florida in Gainesville, Chance, was a top program, and it was accredited, okay, meaning it had been determined by the ACGME to meet all the standards of training and education for residents in neurosurgery. and it was accredited by the Neurosurgery Accreditation Board, which my former mentor, Dr. Marty Weiss, was the chairman of that board. He was the chairman for many, many years, like 20 years, and he knew all the neurosurgery programs, and he accredited them with the rest of the board members. So Dr. Weiss would accredit these neurosurgery programs around the country. There are about 120 of them. And if you graduate from 7 years of training in an accredited neurosurgery training program, you are then board eligible. But to get board certified, you have to take tests, you have to have an oral exam and a written exam, you have to pass them, you also have to submit cases, and they review your cases like, did you do the right treatment, did you do a good job? So they review cases, you pass an oral exam, written exam, and then you are board certified. I was board certified after my training. Every neurosurgeon, every type of doctor wants to be board certified. Some of them don't pass the test. It's getting harder and harder to become board certified. If you're not yet board certified and you haven't passed the test, you may be still board eligible. Now, when I finished my neurosurgery program, it took 7 years, and I got my certificate. So from the day I graduated, I had exactly 5 years. Like everybody else, we have 5 years to pass our oral boards, our written boards, and submit our case logs, and basically become board certified. So as long as you're in that 5-year window from graduation, you are board eligible. You are eligible to take your board exam and become board certified. Once you get past that 5-year window, and there are people who miss it, excuse me, then you are no longer board eligible, okay? And life sucks, pretty much. So you don't ever want to miss your board exams. But there's still a way back. You have to basically start over in terms of paperwork and exams and everything, and take the written exam again. So that's the difference between board eligible and board certified.
Okay, and then we have another one, and this is kind of mine. When you were in your residency, how many surgeries did you participate in? Because that guy who was killing people, in his residency, he participated in fewer than 100 surgeries. So
Yeah.
Your reaction kind of says it all.
Yeah, so the question is a good one, and it's about certification again, and qualifications and training. Just to back up, so I was a medical student at USC in Los Angeles, University of Southern California. And basically, I got it in my head that I really wanted to be the best at what I did, whatever it was. And at the time, it was orthopedic surgery. I was going to be the best orthopedic surgeon. So to be the best, you have to go and train with the best. Yeah. And that's why when I finished med school and I was looking at neurosurgery programs, where should I go? I was very lucky that my chairman, Dr. Marty Weiss at USC Neurosurgery, was also the chairman of the residency review committee. And he was in charge of going around to the 110 accredited neurosurgery training programs in the United States and assessing them. And he told me the best training program in the United States for you is the best training program in the United States right now in the year of 1996-97 is University of Florida in Gainesville with Dr. Roten. The second best is probably with a guy named Buzz Hoff over at Washington State, or University of Washington in Seattle. So those are his two top choices, and the third one was Michigan, Ann Arbor. And actually that was Buzz Hoff. The chairman in Seattle, I can't remember his name, but he's no longer chairman there now. So those are the top 3 programs in the country for training. So what does that mean? Well, it means that those programs did a wide breadth of neurosurgical cases, and they did a large volume of neurosurgical cases. So basically, the lower quality neurosurgery training programs in the United States, they don't get enough neurosurgical cases. And they don't do enough aneurysm surgery, AVM surgery, pediatric neurosurgery, kid brain tumors, hydrocephalus, whatever it is, pituitary tumors. See, neurosurgery is this field of surgery where we deal with brain tumors, tumors of the face, the skull, also congenital abnormalities like, spina bifida, Chiari malformations, and pediatrics like kids with brain tumors and deformities of their spine. And then we deal with peripheral nerve abnormalities, and we deal with spine, everything with spine, trauma, tumor, infection, and degenerative. So basically there's literally 1,000 different types of neurosurgery procedures out there that I could do. And the problem is that a lot of neurosurgery training programs don't do enough of those cases. They don't see enough because a lot of those things are rare. Like there are really rare conditions, like this thing called diastematomyelia. It's where your spinal cord comes down and gets split in two by a piece of bone sitting in the middle of the spinal canal. Well, I mean, I saw one of those in residency, but that's one more than everyone else in the country because it's such a rare abnormality. So basically, the quality of a neurosurgery training program depends heavily on the attending physicians, how competent they are, how good they are in their fields. And we had amazing attendings in all the fields. And then because they're so amazing, they get referrals from all over the state of Florida for aneurysms and ABMs, or for spinal abnormalities, or for pediatric brain tumors and things. And because the attending physicians, if you watch Harry Potter and Hogwarts, it's like the faculty, right? And all those faculty are really good. That's why they're there teaching. So we had some of the best faculty in the country in their respective fields, and they got referrals from all over the world. And because referrals came from all over with those specialized problems, Dr. Roten, for example, did a couple of procedures. He did pituitary tumors through the nose, where he would do it endoscopically through the nose. He also did pain, something called trigeminal neuralgia, which is basically the fifth cranial nerve that goes to your face, has 3 branches, and it can get, those branches of nerves can get pushed on by an artery. So Dr. Roten would go in through the back here, he would open up the skull, move the cerebellum over, and he'd put a cushion between the little artery, like the superior cerebellar artery, for example, and he would put a cushion between that artery and the nerve so that the pain in the face would go away. And he was like, of all the neurosurgery programs in the country, there were only like 5 of them that did this procedure. So he was top in the country and the world, and he had people from all over the world coming here to have the surgery, but also to learn from him. So I was fortunate to be in that environment where I had attendings that did all these complicated cases in neurosurgery, so I got to do all that cases. So when I got out of training, I was very competent at just about everything in neurosurgery. I just ended up doing spine because I like it. So this guy that we're talking about, Dunce, right? He only did 100 surgeries. That's terrible. That means he went to a really shitty neurosurgery program that didn't do a lot of cases. I'm going to give you an example. It's kind of a funny story, but since I'm kind of bringing out my life story in all these videos and sharing it with you all, when you're getting ready to graduate med school and you want to go do residency in neurosurgery, you have to go interview at all those programs. So the way it works is you send them a letter called an application. They want to know your grades in medical school. They want to know your honors, your accolades, everything. They want to see the whole picture of who you are. Then they look through that and they take the top people and they say, we like you, we like you, we like you, we like you. So they pick about 20 medical students that are graduating that they like from around the world, the best schools, and they offer an interview. So they say, you're welcome to come here and check out our program on this date or this date or this date. So they give you like 3 dates. And when you show up, there's 10 other residents just like you that are also looking to go into neurosurgery, and they're from different programs. So you get to know the other resident applicants pretty well. And as I was traveling around the country going to my interviews, it's all happening with over like a 2-month period of time. You got to rush and get out there and do your interviews. So I'm flying to Washington and Seattle, and then from Seattle, Washington, I fly down to Phoenix, Arizona, and then from Phoenix, I would fly over to Harvard. And so one of my trips, I had a layover in Colorado, all right? Now, I'm sitting there getting off the plane, looking at my itinerary, and I fly out of Colorado that night. And I got in the morning, and I'm like, I was a little tired, and I'm like, you know, I think I'm just going to go to I got the whole day to kill. I'm going to go ski. So I get in the cab and I'm like, take me to the mountain. I want to go snowboarding, right? I thought, I got a whole day. I'll kill it on the slopes. As I'm on the highway heading up to the mountain, I just start thinking to myself, it's so strange that I gave myself a day of snowboarding in the middle of interviews. This is weird because I didn't have any money. I was poor, but I had enough to go skiing for a day. And as I'm passing by the University of Colorado, it's off to the left. Yeah. And I'm looking at it, I'm going, the University of Colorado. And they go, oh no, I have an interview there today. So I interviewed at the University of Colorado for neurosurgery, not because it's a good program, but quite the opposite, because I thought, I'll go check it out. My mentor, Dr. Weiss, gave it like a B minus, as a grade. So he didn't want me going there. He's like, it's not a good program. But I went there anyway, and I was going to check it out, right? So one of the things I did when I got there is I always asked the program, how many aneurysm surgeries do you do a year? How many AVM surgeries? These are like rare, complicated surgeries. But I'm getting a feel for like the kind of training I can expect to get. So I get to the university, and I asked the chairman, I'm sitting there with the chairman, he's like, we'd love to have you here. I'm like, yeah, that's great. I like it here, but can I see your case logs? How many cases you did? And what kind of cases? He gave me the case logs, and it was like VP shunt, VP shunt, VP shunt, ACDF, microdiscectomy, VP shunt, laminectomy. And I'm like, where are the aneurysms? Where are the AVMs? They did like one aneurysm a year. I'm like, no, I would get terrible training. So why did I give you this long story? Well, because, there are, unfortunately, neurosurgery training programs that suck really bad. They don't do enough cases. They don't have the right faculty. And honestly, they should probably be closed down because the doctors coming out of them are not competent. But who am I to say? I'm not on the board, and I don't do residency review stuff. So, but that's the truth. There are, unfortunately, a lot of incompetent surgeons being released onto the United States, not just in neurosurgery, but orthopedics and every other specialty, and also non-surgeons too. So I feel badly for everybody that they have to figure out who's a good doctor, that there's really no standardization. There should be, but unfortunately there's not. So I don't know if I answered the question well, but we're done? Yeah, we're done. All right, hope you enjoyed the surgeries and our dialogue, and remember to check out the Deuk Spine Institute app on your phone. We're getting ready to release another version. We also have the animation for microdiscectomy coming out next week with Zach and I have been working on. And Diego is going to work on that as well with John. And we'll have that released so you can learn more about microdiscectomy and how bad of a procedure it is. Also, we have, of course, more reaction videos and more spine scams exposed and testimonials that will be coming out this week. So check us out on YouTube. Go check out the Deuk Spine Institute YouTube channel and have